visited us from a Middle Eastern country. And he had to go back and he got continuing care when he returned home. And these are some of the keratoconic corneas that we work with. On the left is a nipple cone. On the right is a global cone. Again, here is a very, very thin nipple cone with a scleral lens over that. This is pretty rare. This is a superior pellucid marginal degeneration. When this patient came to see us, his visual acuity was less than 21,000. We fit him with a scleral lens, and his visual, we got him to 20/25. But you see how pronounced the superior aspect of that cornea is. You can see the matching topography. This patient was a cab driver in another country, and I asked him how could he drive a cab, and he told me he had the roads memorized. But let's move on. The photo on the left, you can see high drops there, but this is actually post-LASIK corneal ectasia on the left. It's not, you can call it PMD, but it's a post-LASIK corneal ectasia. On the right, you can see the high drops on a global cone. We fit both of these eyes with scleral lenses. And this, again, acute onset of high drops. We treated this eye medically for about 2 or 3 weeks, very aggressively with various eye drops, including Timolol, Mura 128, and Pred Forte. And this eye, after 2 or 3 weeks, cleared up. 85% of that high drops, that haze was gone. So now we'll talk about asymmetric back surface designs. So more often than not, the sclera going around the clock is not symmetrical. There's asymmetry. You can fit one part of the eye well, and the other part, the lens may be lifting off or impinging on the conjunctiva. So for these situations, quadrant-specific scleral lens designs may better address these unusual asymmetric sclera. So this is a computer we use, an imaging computer called the SMAP. There are several companies that are involved with this. The technology is referred to as profilometry, where we're mapping out not just the cornea, but the profile around the cornea. And with this instrument, we take 3 images of each eye. The images are stitched together to get one whole image. And you can see the colors represent asymmetries going around the clock. These images are uploaded to a special lab, and they have the software to design a lens where the lens, the landing zone, the peripheral portion of the lens matches exactly the contour of the sclera going around the clock. Another technology that I really enjoy working with is called eye print or impression technology. This particular patient has a glaucoma shunt going from 6 o'clock toward the pupil. You can see on the bottom left, you can see an image of that glaucoma shunt. And we took an impression of this eye, and we had an eye print pro scleral lens made where that shunt was taken into consideration. You can see the bottom right, the outline of the eye print pro scleral lens that's designed to vault over that shunt. And the patient was quite comfortable with this particular design. Here's another patient with a glaucoma shunt. This time the shunt was around 11 o'clock, and you can see the outline of the shunt. But look at the eye print pro, the impression that we took. You can see the outline of the glaucoma shunt in the impression, and the resultant eye print pro scleral lens vaults over this patient's eye. This is the eye of an 11-year-old girl who had cataract surgery when she was under 3 years old, glaucoma surgery, and so forth when she was just under 3 or 4 years of age. And the patient's seeing very well with this lens. Here's another time we used that technology. This eye underwent 5 prior corneal transplants, 2 shunts. you can see the arrows pointing to the shunts and to the huge blebs on this eye. Now, one problem that we all have to deal with or contend with on these high-need patient populations are higher-order aberrations, where they're seeing halos and glare, starbursts, double vision, shadowing, and this is examples of some of the things that patients see. And there's emerging technology involving aberrometry that are designed to take care of these. So this is a company in this country called Ovitz, O-V-I-T-Z. I don't have it written down here, but their website is Ovitz, O-V-I-T-Z.us. So for those watching, please write that down. It's a very interesting website where they talk about addressing higher order aberrations. Again, OVITZ.us. So we take images of a lens. We send the images with the HOA readings to a laboratory associated with University of Rochester, New York. They take that image, that information, send it to the lab. The lab in this case is iPrint, and they embed that into the optics of a scleral lens. So we call that kind of lens a wavefront design scleral lens. And this shows the before and after, when we do the imaging before we have the Zernike images, before we have the HOA's technology embedded in the lens, before and after. You can see the difference. Another way for patient education, we'll use our topographer to do a point spread function to show how a point of light is dispersed on a keratoconic cornea, for example. And then when we put a scleral lens on, do the same topography, do the same point spread function measurement again, and you can see the difference before and after. On the left, the image shows the distortion of the light as it enters the eye. On the right, you can see a much better imaging. That's why a scleral lens will take care of, for the most part, higher order aberrations. RK surgery was very popular from about 1985 to 1993. And then with the advent of LASIK surgery, very few people do that anymore. This is an iPrint lens over a post-RK cornea. You can see all the cuts. This patient has no functional vision with his eye until we fit this eye with a scleral lens. Here's an eye that underwent 3 RK surgeries over 30 years ago, 3 separate RK surgeries, followed by 3 separate LASIK surgeries many years later, followed by a corneal transplant surgery about 8 months ago. You can see the cuts, you can see the outline of the LASIK flap. Here's another eye that underwent RK surgery, followed by LASIK surgery many years later. I've never seen anyone who had multiple surgeries come out on top of this. Usually what they call enhancements make things worse. There are multiple corneas of eyes that underwent LASIK surgery after RK surgery. All of these people needed scleral lenses, all of them. So this is an eye of a 5-year-old girl who was working out an exercise machine while her mother was doing something else. She wasn't being monitored properly, and something snapped and perforated the cornea. She had a retinal detachment. The lens, she had a vitrectomy. Her own lens in her eye had to be removed. So this is an aphakic eye, and we fit this eye with a scleral lens. And so this is where trauma comes into effect, where a scleral lens can really help out a patient. Here is another eye. This patient was taking medication for restless leg syndrome. And during cataract surgery, the patient's body and leg shook violently. It took several technicians to hold him down. All of this while the cataract surgeon was inside the eye. So you can see part of the iris is ripped away, and you can see the IOL there. And in any case, the patient's doing really well with this, put a scleral lens. You can see the outline of the scleral lens in the top left. You can see the outline, top right also. These are three different eyes that we worked on with the scleral lens. And again, very often I've noticed that when you're dealing with a transplanted cornea, you're going to see a tilt. Look at the outline of the OCT image below. Notice how there's a tilt in there. And you fit this eye with a regular scleral lens, and maybe it touches one area or rubs against one part of the cornea, and you have clearance in another part. Well, I don't want rubbing on a donor cornea because I don't want to take a chance on any rejection. On eyes like this, I tend to use either the SMAP 3D computer to map out the lens, the front of the eye, or we'll take an impression. In this case, we took an impression of this eye, and this is an iPrint Pro scleral lens. So the back of this lens is designed to match perfectly every hill and valley on the front surface of that eye. So we don't have any rubbing taking place. Fits really nicely. This is an eye that lost vision from shingles, a very distorted cornea. And this is an 80-year-old woman. This is her only eye. The other eye, she was born with a blind eye. She's terrified of having a corneal transplant. We fit the eye with a scleral lens. This patient with the lens has around 20/80 vision, which is good enough for her. She lives alone, lives by herself. And if she needed a transplant, there'd be nobody to take her to the doctor or to the hospital. So she's wearing this lens. She has an aid that helps her insert the lens and remove the lens. This is a photo of a transplanted cornea over an eye, autoimmune disease. This patient has lupus, and you can see the virtually no meibomian glands. At the arrows are pointing to a little bit of the pieces of the meibomian gland, upper lid and lower lid. And we fit this eye with a scleral lens, and the patient has fairly good vision. And this is the second transplant that this patient had to undergo, but the eye's been quiet for quite a while. If you look carefully, you can see some neovascularization going onto the donor cornea. That's not really a good sign. We don't want neovascularization on a donor cornea. So that's that on that. This is a patient. This is a patient that had multiple blepharoplasties. He's a performer and didn't want wrinkles under his eye. It turns out that after multiple surgeries, eyelid surgeries, he can't close his eye. And we asked this patient, close your eyes as tight as you can. And that's it, what you're seeing over there. And we fit this patient with two different scleral lenses, one pair of scleral lenses to wear when he sleeps, another pair during the day. And when I first met this patient, he told me he had not slept in 2 years. So I see him regularly. He was just here the other day, and I was going to do a refit on one eye. And I said, you can't wear the lens for a couple of days. And he said to me, how am I going to sleep? So that's another issue. So Stevens-Johnson syndrome is a degeneration, very poorly understood. Apparently, it's a result of reaction to one's body to medication like penicillin, maybe some steroids, other medications. And here you have a top right, a photograph of an eye with Stevens-Johnson syndrome. That central area, this patient's from another country. That cornea perforated. The doctor used crazy glue to seal up the perforation. The patient came to Miami to have medical treatment done. We fit that eye with a scleral lens to protect it in anticipation for a surgical procedure that was be done here in Miami. The bottom right eye is also a Stevens-Johnson. This is a very rare photo. It's virtually unheard of to see a corneal transplant on a Stevens-Johnson eye, but this is the patient's only eye. The cornea perforated. The surgeon had no choice but to do a transplant. Miraculously, with the scleral lens, this patient has virtually 20/20 vision. But I took care of this patient for 10 years before this event took place, and he was seeing 20/30 with a scleral lens. Then the cornea perforated, and after the surgery, he's doing very well, almost 20/20 with a scleral lens. This is a very rare condition known as Peters anomaly. The symptoms are there's cataract, no iris, no pupil, a hazy neovascularized cornea, sometimes scarring, glaucoma. This patient is aphakic, had her own lens removed. There's no iris to hang on an IOL, so there's no intraocular lens in that eye. You can see all the neovascularizations. There's no functional vision. Again, this is the patient's only eye. And to give her a pupil, we fit this eye with a blackened soft lens. We gave her a 8mm clear pupil, and over that, we put a scleral lens. So with the blackened pupil, with the blackened soft lens and the scleral lens, the patient has 20/80 vision. Without this scleral lens, soft lens combo, the patient's visual acuity is basically hand motion. This is her only eye. She lives by herself also. And she has a job now. She works in a nursing facility and empties out the trash and does menial work, but she has a job. This is again, a very, very rare condition known as gelatinous drop-like corneal dystrophy. It's genetic. There have only been a few cases like this documented in the world, mainly in Asia and principally in Japan. This patient is visited us from the Middle East. And this also, it's a young boy, 11 years old. This is after the second corneal transplant. With the scleral lens, the patient, again, without the lens, the patient's visual acuity is less than 21,000. With the scleral lens and eyeglasses over, the patient's able to identify around 20/70 vision. And his corneal surgeon, that he's on a waiting list for another transplant in about a year. So this is where a scleral lens can actually change your life and save a life. And that's, I think I wound up early, but that's my presentation. So I want to thank you all for listening to me. These are my websites, and that's my email address. Anyone, you're welcome to contact me, call me, whatever. So.
Thank you indeed, Dr. Edward Boshnick. Someone told me that it's your birthday, so happy birthday.
I'm trying to ignore that. Thank you very much. Yeah, thank you.
So that was a very wonderful talk, very well illustrated. I could say a word. I think that extreme cases
to make a ladder
need extreme technologies. That's what I felt. I felt that you are using a lot of means which are not commonly used at the moment in most of the countries, such as the SMAP 3D Ocular Surface Profiler, the iPrint Pro impression, and the Office HOA facilities, which could help people seeing better.
Well, yeah, Pentacam is coming out with also profiling technology, Pentacam, and also there's company makes a profiler called the Eaglet, and I think that's a European company based in the Netherlands. So that can also be used. It's called the Eaglet. I think it's being used in Europe.
Yes, yes, it is. It is actually. I think that we have seen the good side of the scleral lenses in some desperate cases, but I wonder if scleral lenses have also maybe if we have a lot of clearance, very deep clearance. Is there a risk to have hypoxia? And also, I'm wondering about this story of pressure IOP increase with some sclerals, which has been in the literature for the few last years. What do you think?
I think there might have been some isolated cases where there was increased intraocular pressure after wearing scleral lenses. I have not seen that. We check everyone, their pressure before, we do it during their fitting period, and when they do come in for follow-up visits, we check everyone's pressure with several different pieces of equipment. So I've never witnessed this. I think maybe it was documented in one or two cases, and a case presentation was done in a journal, and next thing you know, the internet comes up with various theories. I don't think it's a real thing. I really don't think it's an issue. Now, as far as for clear, you mentioned about clearance, which is, the sweet spot to me is you want to try and get around 200 microns of clearance. Sometimes you want 250 or 300. That's okay. You don't want to have like 500 microns of clearance. You're gonna have problems, and you really don't want under 100 microns. But we have OCT technology where we can. I use an instrument made by Zeiss. It's called the Visante. Resolution of that instrument is 7 microns. We measure that carefully.
Okay. One of your first slide on the bad landing and good landing.
Can you get back to me? Yeah. Can you get back to me on that? One second. Yeah. Let me go to that. Let me go to that. Yeah, you can see the edges digging into the sclera.
Yes. One side, I can see one side. It's yes.
This was not my lens. This is what a lens a patient came in with, so I'm innocent on that.
Okay. It's digging inside the sclera, as I.
It's into the conjunctiva. Yeah.
Yeah. Yes. And what's the ideal landing for you?
Like that.
Okay. It's kind of tangent.
It's tangent to the sclera. Yeah. You want a tangent, and the longer the landing zone, as a rule, the better it is. It's like if a woman steps on your toe with a high heel shoe as opposed to a sneaker. You're distributing the weight of the lens over a wider area. It makes for a more comfortable fit.
Personally, I found that one of the difficult cases are pellucid marginal degeneration, because it's not so obvious to get the clearance at the bottom of the edge at 6 o'clock. You are using some new technologies, but we are using most of the time scleral lenses, which are not manufactured so precisely. So, what's your advice?
Well, if I was fitting a scleral lens, I want to vault over that part of the cornea, and sometimes you can only get by with maybe 50 or 80 microns of clearance, but you want to clear that area. After it settles down, try to have less, 80 to 100 microns. And then so it's at 12 o'clock in the upper portion, you may have 300 or 400 microns of clearance. Then below, you have 80 microns. You do this to do the best you can. But there's a very fine laboratory in the Netherlands that can work with a lot of the doctors on that. I think it's Visser Lens. Have you heard of that company, Visser?
Visceral lens, yeah, yes, yes.
Yeah, I mean, but there are companies, there's technologies out there that can help you out with that. Nothing is perfect. You just try to manage it as best you can.
Okay, another question before I will try to get some questions from the audience. I have seen most of your slides are, I think, full scleral lenses. It's a 16.5 or larger than that. Do you work with semi-sclerals or not?
You know, I don't use the word semi-scleral. It's either a scleral or it's not scleral. It's either a woman is pregnant or she's not pregnant.
No, 14.9 or 15.
Well, those are small lenses, but you're going to probably hit the limbal area. So the lenses I design are usually 15.6 or larger. And sometimes you have to, you think of it like this. If you have a big house, you need a big roof. So it all depends on what I'm dealing with.
Okay.
And on the my regular scleral lens designs, forget about the eye print, but on the regular scleral lens designs, I always fit lenses with reverse geometry. And usually the lenses, as far as the secondary curve is concerned, it's 4 diopters steeper than the base curve. Okay, so my regular standard scleral lens designs are all reverse geometry. That helps me give a lift over the limbus. It just makes for a better fitting lens. I don't get edge lift off that way.
So you don't use at all trial lenses, I
have trial. My diagnostic lenses are all 4 diopter reverse. Yeah, my trial lenses I really use a lot are Jupiter scleral lenses. I have them in all diameter. I have 15.6, 16.6, up to like 18, and also 20 millimeter scleral lenses, but they're all reverse geometry. So a little thing I've learned over the years, my life is easier when I design lenses with reverse geometry design.
Okay, but most of the time, when you are taking, as an example, when you're using the iPrint Pro impression, do you have to send back again the lens to be to do some other?
Well, I don't send the lens back. What I do is, if I need, let's say I need to have more clearance, I'll just tell the lab I need an extra 100 microns of clearance, or I'm getting some limbal staining, or there is an impression at 3 o'clock or 9 o'clock. I'll take photographs, send the photographs and all the imaging to the lab, call them on the phone. They're looking at my images and photographs while I'm looking at them, and they understand what I need to have done. They make up new lenses. We don't send the lenses back.
We have from Dr. Wazani a question on the chat, if you wouldn't mind to look at the question.
Sure.
What is the best diameter and central lens thickness you use in penetrating keratoplasty patients? Second question, how many lenses you change generally to have the final lens?
Okay. What's the best diameter? Okay. Most of the lenses that I use on, well, most of my transplant patients, I use either the iPrint or the latitude lens, which is designed from the SMAP, from the profiling. Those lenses are usually 17.5 millimeters. I let the lab determine the diameter based on the images, but they usually are 17.5 millimeter. Once in a while 18, but that's usually it. As far as central thickness, I don't tell the laboratory about central thickness. I don't measure it, and I don't ask them. Maybe I should, but I don't. It just works out well. Let them do it. Second question, how many lenses? Gee, sometimes I have to go, sometimes it's 1 or 2, rarely 1. It's sometimes 2 or 3. When there's complications, whatever, sometimes I may go 3, 4, or 5. It all depends on the person. I don't know if I'm answering the question. It could be, everyone's different and unique. Sometimes you get a patient that's really easy, and sometimes someone you want to pull your hair out.
Okay. We'll have a third question from Dr. Wazani. Do you think that the future of scleral lens fitting will be guided by artificial intelligence?
Wow, that's a great question. That's a great question. I think that's a possibility where artificial intelligence will tell you based on the parameters of what we're looking at and the corneal thickness and the diameter, whatever, this might be the best type of lens design for that patient. Maybe. I think we're a long way from that, but who knows? Great question.
Okay. Any advices for young fitters? Do you think that investing in new technologies such as OCT, SMAP, and iPrint will
I think profilometry like the eaglet, which is available in Europe and maybe other parts of the world, are something really you should consider. It'll make your life a lot easier and get a more accurate fit. OCT, I mean, I can't function without OCT to look at the relationship of between the lens and the cornea, between the back of the lens and the cornea. I mean, it's so precise. Back before I had OCT, I was putting fluorescein on the lens and looking with a narrow slit lamp beam to figure out how much clearance I had, which was to me prehistoric. I mean, it's so old.
Sorry, Ed. Do you mean that you don't use any more fluorescein and slit lamp?
I do fluorescein and slit lamp to make sure the edges are valid, but not to determine the fit. No, okay. It's all done with OCT.
So you think that OCT will be a gold standard for sclerals in the future?
Absolutely. There are several companies out there. There's a German company called Heidelberg that's came out with a new anterior seg OCT called the Anterion, which they haven't really marketed, but that's available maybe in Europe by Heidelberg. And I'm sure Zeiss and other companies are going to be coming out with anterior seg OCT.
Yes, for the OCT AS, most of the companies now are offering in their OCT this possibility. It has become a kind of something very natural. I have a Hughes OCT, which has also an anterior segment model. So the thing is that we have to change every time to put the lens and so on. It's a bit tricky. I know that there is a company which we don't need to put the lens, to put the ocular, the other side of that.
Can I turn this around so they can see? Look, can you see? This is my, we have Abby. Can you point to can you see the OCT? Can you point to it? That's my anterior seg. Yeah, that's it. Yeah, I know if you can see. That's my anterior seg OCT. It's right near my chair. So it sits around 7 or 8 feet away. So I go from the chair to the OCT and back and forth. So I do it very fast. It's just very fast. I can just look. It just takes me, seconds. In a matter of a few seconds, I can see what I'm dealing with. Saves me a lot of time.
So, of course, you are doing most of the time specialty lenses. Most of the time, you don't do optometry, general optometry.
No, we don't do anything with eyeglasses. It's everything we do is contact lenses, mainly scleral lenses.
Okay, that's right.
Yeah.
It's a really a new development, I think. With OCT, we can see the clearance, we can see the landing, we can see everything, and we can also manage to see even the angle.
Yes.
That's
and I think going forward in the future, this aberrometry technology is going to blossom out. You're going to see more laboratories utilizing that information to embed it into the optics of a scleral lens. I don't understand it very well. I know it works and it's available here. And if it's available here, it's going to spread other places in the world.
I think the aberrometry is becoming very nice and useful tool. I use aberrometer with I'm most of the time using RMS high RMS,
Yeah.
mean square for high aberration. So of course we don't have. We still have, after having the lenses, we still have some higher order aberration. Nevertheless, we are giving maybe better image to much better image for keratoconus conus people and ectatic people than with the specs or with the soft lenses. That's certain.
Yeah, I think the world is changing so fast that in 2 or 3 years from now, what we're talking about right now may seem like ancient history. But I think the changes are taking place faster, and better things are going to come along in the next year or 2 years.
We have a question. We have a question from. It's in French. I'm sorry, but I will try to translate it.
Sure.
Je vais la lire en français, ensuite je la traduis. Est-ce que vous utilisez des autres indices quantitatifs pour minimiser les HOA ou bien seulement PSF? Do you use other index, quantitative index to minimize the higher order aberration, or just the MTF?
Do I use
Other value which your aberrant is giving to you, such as RMS and.
no, I only use this one. I only use the one technology from OVITS, OVITZ, OVITS. I don't use anyone else. I use that, and they have a relationship with a few different laboratories they work closely with. So that's the only thing. I don't use any other aberrometry. If I'm gonna measure higher order aberrations, I have to have a way of taking care of the problem. And the laboratories work with the OVITS to design a lens. So I take the images with the aberrometer. That is uploaded to a laboratory associated with the University of Rochester. They do something with that information, send it to the lab in iPrint, for example, and they take that information and embed it into the optics of a lens. That's what I do. There's nothing else. No other technologies other than that I work with.
Okay.
I don't know if I answered this question.
Yes. I think that you are using OVITS technology. You are using OVITS aberrometer also.
Yes. Yeah.
It's a kind of technology which is which can give you the ability to order your lenses with the treatment of the aberration, of the higher order aberrations.
Yeah, maybe some of these things that we're using are not available right now, but they will be. You know, technology, information spreads all over the world. So you're not going to find an isolated area where technology exists and it doesn't go anywhere else. It's like viral. It'll move around.
For ocular surface complications such as ocular surface disease, dry eye, and so on, how much clearance do you advise people to do with 17?
I would try to be after the lens settles down. That's as important because sometimes these lenses can drop 100 microns. So after the lens settles down, I would want at least 200 microns of clearance, at least.
Okay.
However, let's say, you're dealing with irregular corneas. So maybe you have 300 microns looking at the eye, let's say at 3 o'clock, and then toward 9 o'clock, you have 50 microns of clearance. You have to increase the clearance.
Okay.
Or design a lens it's appropriate for a very distorted cornea.
For the people who have had herpes zoster herpes or adenovirus herpes conjunctivitis, and they have irregular surface, some people are thinking that putting contact lenses, even scleral lenses, will put in danger, at risk the cornea. What do you think about this?
I don't think so. If the lenses fit well and you follow the patient along, everything has a risk, but the you have to take into consideration the risk-benefit ratio. And when it comes to these compromised corneas, the risk-benefit ratio is definitely going to be in favor of the patient. So as long as the patient is being watched, monitored, I don't think there's anything to be concerned about.
Some people from the ophthalmologist side, I have some cases who they have advised their patients to
Well, these guys don't understand scleral lenses and the impact it can have on a compromised cornea. And if you don't understand something, the natural tendency is to throw a rock at it. Okay.
Okay. I don't think that there are a lot of questions at the moment. We have your email. I think most of our members are following your posts, who are becoming very popular in our page and other pages such as SMT and so on. So I think that I started with extreme cases need extreme technologies. I think that each case need to be monitored, not to be taken with very with wise and very good care. And so also we have to invest in the new technologies which can give us the possibility to fit people with the right lenses.
If the members who are watching this can travel to America next January, you have a major scleral lens meeting that takes place around the end of January in Las Vegas. People from all over the world come to that thing. So I think if I can give you that information if you want. I'll message it to you if anyone's interested in going. But it's every January. It's really an unbelievable meeting. People from all over who are interested in scleral lens technology. And scleral lens technology is really growing in leaps and bounds. Fastest growing, the most interesting technology. Everyone wants to get involved with scleral lenses, and the change, how it can change someone's life is unbelievable. It can take someone who's severely depressed and thinking of suicide and making them a functional human being once again.
One of the most impressive, I think, case was the woman which was a victim of in the Vietnam War, and which was fitted by you. And last year I have seen a picture of you and this lady from Vietnam, I think.
Right. Yeah. Her name is Kim. Her name is Kim. Yeah. It's the most famous photograph of the war in Vietnam.
Yes. That was. Thank you indeed, Dr. Boshnick. I hope that that was not the last time we have to.
I'll be happy to. Thank you for inviting me. It was a real treat for me to do my to explain what I do. But thank you very much. Okay, and I appreciate it. And I'll send you information on the meeting in Vegas next January.
Thank you indeed. Thank you indeed.
Okay. Take care.
Take care. Have a good night.
You
Bye-bye.
too.
Bye-bye.